So check this out. You're 72, feeling great, and your doctor orders a routine screening colonoscopy. 3 weeks later, you're among the 2.3% of seniors aged 76 to 85 who end up hospitalized within 30 days of the procedure. Research shows a small but measurable risk of hospitalization or death after colonoscopy in older adults. Yet many patients never hear about these statistics before agreeing to the test. This scenario reflects a broader issue the medical establishment is finally confronting. The U.S. Preventive Services Task Force now recommends against routine colonoscopy after age 75 for people without symptoms or family history. Yet countless seniors continue receiving outdated recommendations that no longer match current medical evidence. The gap between what research shows and what patients experience has grown too wide to ignore. The medical reality check nobody talks about. Something significant shifted in the medical world during 2024 and early 2025, but most patients never heard about it. Major medical organizations quietly updated their screening guidelines for seniors, though not always in the same ways. The U.S. Preventive Services Task Force now advises individual decision-making for colonoscopy screening between ages 55-69 and recommends against routine screening after 70. Meanwhile, the American Cancer Society suggests shared decision-making for ages 40-44 and annual screening from 45-54. Yet many doctors continue following older protocols, either because they haven't caught up with the latest evidence or because changing established routines takes time. The disconnect between what medical societies now recommend and what actually happens in doctors' offices has created a dangerous gap. Patients over 70 walk into appointments expecting the same battery of tests they've received for years, while the evidence increasingly shows these screenings may cause more problems than they solve. The medical establishment has always been slow to change direction, but this particular shift involves admitting that procedures they've championed for decades might actually harm the people they're meant to help. This communication breakdown leaves seniors in a vulnerable position. They trust their doctors completely, which is admirable, but it also means they rarely question whether a recommended test makes sense for their age and situation. The medical system has trained patients to believe that more screening equals better care, but the reality for older adults is far more complicated. The same test that saves lives at 50 can create serious problems at 75, yet this nuance rarely gets explained during busy medical appointments. The evidence that accumulated through 2024 and into 2025 revealed something striking. 5 specific medical tests that form the backbone of senior healthcare have been quietly downgraded or actively discouraged by major medical organizations. These aren't fringe procedures or experimental treatments. These are mainstream screenings that millions of seniors receive every year, often without understanding that the medical community's thinking about their value has fundamentally changed. The American Geriatric Society, the American Academy of Family Physicians, and multiple specialty organizations have issued position statements that directly contradict what many patients expect. They've examined the evidence and concluded that for healthy seniors without specific symptoms or risk factors, certain widely used screenings cause more harm than benefit. The studies behind these recommendations are robust and clear, but translating research into practice takes time, especially when it involves telling people to do less rather than more. This isn't about abandoning medical care or ignoring serious symptoms. The distinction is crucial. When you have chest pain, shortness of breath, or other concerning symptoms, appropriate testing and treatment remain essential. The problem lies with routine screening tests performed on people who feel fine, where the goal is finding hidden problems before they cause symptoms. For older adults, this approach often backfires in ways that younger patients don't experience. The tests we'll examine have become so problematic that many experienced doctors refuse them for their own elderly parents. This creates an uncomfortable situation where physicians recommend procedures for patients that they wouldn't choose for their own families. It's not malicious or hypocritical, but it reflects the complex pressures doctors face in clinical practice. from liability concerns to institutional protocols that haven't caught up with the latest evidence. Seniors present unique challenges for medical decision-making because they're often the most compliant patients. They follow instructions precisely, rarely question recommendations, and genuinely want to do everything possible to maintain their health. This admirable attitude makes them particularly vulnerable to overtesting. The medical system profits from this compliance in ways that aren't always obvious. Each test generates revenue, and abnormal results often trigger cascades of additional procedures, consultations, and treatments that can spiral beyond what's medically necessary. Understanding which tests pose more risks than benefits requires examining them through the lens of how aging changes the fundamental calculations. The same screening that makes perfect sense at 50 or 60 may become counterproductive at 75 or 80. Life expectancy, treatment tolerance, recovery time, and the likelihood that slow-growing problems will actually cause symptoms all change dramatically with age. Yet the medical system often applies the same testing protocols regardless of these crucial differences. Each of the 5 tests we'll explore illustrates this problem in different ways. Some cause immediate physical risks that older bodies handle poorly. Take colonoscopy preparation, for example. It's like a medical hurricane hitting your digestive system. Kaiser Permanent research shows that the bowel prep process alone can cause dangerous electrolyte imbalances in seniors, leading to more emergency room visits than the actual procedure itself. Other tests detect problems so slow-growing that they'll never cause symptoms in a person's remaining years. Still, others lead to treatments that are more debilitating than the conditions they're meant to address. The goal isn't to create fear about necessary medical care. Symptoms that concern you should always be evaluated properly. Regular checkups with doctors who understand your health history remain important. Medications that help you feel better and function well serve valuable purposes. The issue is specifically with screening tests designed to find problems in people without symptoms, where the evidence increasingly shows that the screening process itself can become the biggest health threat. The evidence from 2025 research shows clear patterns. Seniors who receive fewer screening tests often have better health outcomes than those who undergo comprehensive testing. This counterintuitive finding challenges basic assumptions about preventive care, but it reflects the reality that for older adults, the cure can be worse than the disease. Learning to distinguish between essential health care and potentially harmful overscreening represents one of the most important skills seniors can develop for protecting their well-being in their later years. What makes this situation even more revealing is that many of the specialists who perform these procedures make very different choices when it comes to their own healthcare decisions. Test 1, the colonoscopy conundrum. The first test that deserves serious reconsideration is colonoscopy screening for seniors over 70. Many gastroenterologists over 70 choose to skip their own colonoscopies, even while they continue recommending the procedure to their patients of the same age. These are doctors who understand the risks and benefits better than anyone, yet they make different choices for themselves than what they advise in their clinical practice. This disconnect reveals something important about how the medical profession views colonoscopy screening for seniors, especially when personal stakes are involved. The preparation phase has become increasingly problematic for older adults, with 2025 data showing that emergency room visits related to colonoscopy prep now outnumber complications from the actual procedure itself. The bowel cleansing process requires consuming massive amounts of powerful laxatives that can wreak havoc on senior bodies. These medications force rapid fluid loss and can disrupt the delicate balance of sodium, potassium, and other essential minerals that keep hearts beating regularly and kidneys functioning properly. For seniors whose bodies already struggle to maintain proper hydration and electrolyte balance, this preparation creates a perfect storm of potential complications. The prep process resembles a medical hurricane hitting your digestive system. Just like preparing for a real hurricane, it requires advanced planning, emergency supplies, and sometimes evacuation to safer ground. You stock up on special drinks, clear your schedule for days, and prepare to ride out the storm. The difference is that weather hurricanes are acts of nature, while colonoscopy prep is a choice that may not make sense for everyone over 70. The aftermath can leave seniors feeling weak, confused, and unsteady for weeks, particularly if complications arise during the preparation phase. This brings us to the concept of time horizon, which fundamentally changes the risk-benefit calculation for seniors. Colon cancer typically develops slowly, with most cases taking 10 to 15 years to progress from early changes to life-threatening disease. For someone in their 70s or 80s, this timeline means that even if screening detects early problems, those problems may never progress enough to cause symptoms during their remaining years. The screening process itself may pose more immediate health risks than the slow-growing conditions it aims to detect. Consider Harold, a 78-year-old who felt great and had no digestive complaints when his doctor recommended a routine colonoscopy. The preparation left him severely dehydrated, leading to kidney problems that required hospitalization. During his hospital stay, he developed pneumonia and spent 3 weeks recovering. The colonoscopy itself found only small, benign polyps that would likely never have caused problems. Harold went from feeling fine and living independently to dealing with months of medical complications, financial stress, and reduced confidence in his physical abilities. His experience illustrates how the cure can become worse than any disease the screening might have prevented. Sedation presents additional risks that intensify with age. The aging brain responds to anesthetic medications differently than younger brains, much like how older computers become more sensitive to software updates. What runs smoothly on newer systems can cause crashes and performance problems on older hardware. Seniors often experience prolonged confusion, memory problems, and increased fall risk after sedation. Their livers process medications more slowly, meaning drugs stay in their systems longer and can cause extended periods of cognitive impairment. Some seniors never fully return to their baseline mental function after procedures requiring sedation. The liver's slower drug metabolism in older adults compounds these sedation risks. Medications that clear quickly from younger bodies can linger for days or weeks in senior systems. This extended exposure increases the likelihood of what doctors call postoperative cognitive dysfunction, where thinking and memory remain impaired long after the procedure. For seniors living independently, even temporary cognitive changes can trigger a cascade of problems, from medication errors to falls to loss of confidence in daily activities. Alternative screening methods offer similar cancer detection benefits without the preparation and sedation risks. Fecal immunochemical tests, known as FIT tests, detect blood in stool samples that might indicate cancer or precancerous changes. While collecting stool samples lacks the high-tech appeal of colonoscopy, FIT tests avoid the dangerous preparation process entirely. You collect a sample at home using a simple kit, mail it to a lab, and receive results without any physical stress or risk. It's less glamorous than a procedure in a medical facility, but effectiveness matters more than presentation when it comes to senior safety. FIT tests detect most clinically significant cancers while avoiding the complications that make colonoscopies risky for older adults. The test requires no bowel preparation, no sedation, and no time off from normal activities. If results suggest problems, then more invasive testing becomes appropriate. This approach reserves the risks of colonoscopy for situations where they're most likely to provide meaningful benefits, rather than subjecting all seniors to those risks regardless of their individual circumstances. The psychological aspect of colon cancer fear often overwhelms rational risk assessment in seniors. Decades of public health messaging about the importance of colon cancer screening have created deep anxiety about this disease. Many seniors feel that skipping colonoscopy means accepting certain death from colon cancer, even when the actual statistics show much lower risk. This fear can drive seniors to accept procedures that endanger their immediate health to address theoretical future risks that may never materialize. After age 75, most medical societies now recommend stopping routine colonoscopies unless specific symptoms or significant risk factors are present. The American Cancer Society, the U.S. Preventive Services Task Force, and gastroenterology specialty organizations have all updated their guidelines to reflect the evidence about age-related risks. These recommendations represent a major shift from previous decades when screening was encouraged regardless of age. The new guidelines recognize that the risks of bleeding, perforation, and sedation complications increase with age, while the potential benefits diminish. This pattern of outdated screening recommendations extends beyond colon cancer into other areas where medical thinking has evolved significantly, but clinical practice hasn't caught up with the evidence. Test 2, the mammography maze. Mammography screening for women over 70 presents similar challenges, with major medical organizations issuing conflicting guidelines that leave doctors and patients confused about the best approach. The U.S. Preventive Services Task Force admits the evidence is insufficient to determine whether mammography helps or harms women over 75, while other organizations continue pushing annual screening regardless of age. This uncertainty has created a medical minefield where well-meaning healthcare providers struggle to give clear guidance. The fundamental problem lies in mammography's ability to detect cancers that grow so slowly they would never threaten a woman's life during her remaining years. These tiny cancers, often smaller than a pencil eraser, can trigger extensive medical interventions that cause more suffering than the original problem. The screening technology has become so sensitive that it finds microscopic changes that previous generations of women lived with unknowingly, never experiencing any symptoms or health problems. This technological advancement sounds positive until you consider what happens next in the medical cascade. Gladys provides a perfect example of how mammography screening can derail a senior's life. At 78, she felt healthy and active, volunteering at her church and caring for her garden. Her annual mammogram detected a tiny spot that measured less than half an inch across. What followed was 8 months of medical appointments, a lumpectomy, 6 weeks of daily radiation treatments, and preventive chemotherapy that left her weak, nauseated, and unable to maintain her normal activities. The oncologist explained that without treatment, this particular cancer might have grown large enough to cause problems in 15 or 20 years. Gladys spent her 79th birthday recovering from treatment for a disease that would likely never have bothered her. The mammography appointment itself creates challenges that younger women don't fully appreciate. The compression required for clear images feels like creating mammary pancakes, pressing breast tissue between plastic plates with enough force to cause significant discomfort. For seniors dealing with arthritis, osteoporosis, or shoulder problems, positioning for mammograms can be excruciating. Women with mobility issues struggle to stand comfortably during the procedure, while those with cognitive changes may find the process confusing and frightening. The physical demands of mammography screening increase dramatically with age, yet this reality rarely gets discussed during scheduling. Overdiagnosis represents the core issue with mammography in older women. The USPSTF estimates that biennial screening from ages 40 to 74 could lead to 14 overdiagnosed cases of breast cancer per 1,000 women screened over their lifetime. Think about walking through an old house with a magnifying glass, examining every corner for potential problems. You'll find peeling paint, small cracks, worn spots, and minor imperfections that have existed harmlessly for decades. Similarly, mammograms in older women often detect changes that have been present for years without causing symptoms or health problems. The technology can't distinguish between aggressive cancers that need immediate treatment and slow-growing changes that may never progress to dangerous stages. The medical system treats all detected abnormalities as urgent problems requiring immediate intervention. This approach makes sense for younger women whose life expectancy gives slow-growing cancers time to develop into serious threats. For women over 75, the same logic falls apart. A cancer that takes 10 years to become life-threatening poses little actual risk to someone with limited life expectancy due to age or other health conditions. Yet the medical response remains identical regardless of the patient's age or overall health status. Treatment side effects become more severe and recovery slower as women age, fundamentally changing the risk-benefit calculation for mammography screening. Chemotherapy that might cause temporary fatigue and nausea in a 50-year-old can devastate a 75-year-old's immune system and physical reserves. Radiation therapy that heals quickly in younger patients can cause permanent skin changes and chronic fatigue in seniors. Surgery that represents a minor inconvenience for middle-aged women can trigger complications, infections, and prolonged recovery periods for older patients. The same treatments that save lives in younger women can destroy quality of life in seniors. The emotional complexity surrounding breast cancer fear makes rational decision-making about mammography screening particularly difficult for older women. Decades of awareness campaigns have created deep anxiety about this disease, with many women believing that skipping mammograms equals accepting certain death from breast cancer. This fear often overwhelms statistical evidence showing that mammography's benefits decrease with age while its risks increase. Women who lived through friends' breast cancer diagnoses carry emotional scars that influence their medical decisions long after the rational risk-benefit calculation has shifted. Clinical breast awareness offers a gentler alternative to aggressive mammography screening for older women. This approach involves women knowing how their breasts normally look and feel, reporting any changes to healthcare providers promptly. Your hands provide more reliable information about your body than any machine operated by strangers. Women who know their bodies will often detect meaningful changes earlier than mammograms would find them, without subjecting themselves to the risks of routine screening. The American Cancer Society acknowledges that mammograms can miss cancers and may require additional testing when abnormalities appear, creating cascades of medical interventions that may not improve health outcomes. False positive results occur frequently in older women, leading to biopsies, additional imaging, and months of anxiety about cancer scares that turn out to be benign changes. These false alarms take significant emotional and physical tolls on seniors who may not recover their baseline confidence and well-being after cancer scares resolve. Many breast cancer specialists now recommend individualized screening decisions rather than automatic annual mammograms for seniors. This approach considers each woman's overall health, life expectancy, personal values, and willingness to undergo treatment if cancer is detected. Women with multiple health problems, limited life expectancy, or strong preferences against aggressive medical interventions may choose to forego routine screening while remaining alert to symptoms that warrant evaluation. The pattern of well-intentioned screening causing unintended harm extends beyond women's health into areas where the disconnect between medical recommendations and actual outcomes has become equally troubling. Test 3. The prostate screening predicament. Prostate screening presents an even more complex situation, one that has divided the medical community and left countless men over 70 facing difficult decisions about their health care. Richard Oblin, the scientist who discovered the prostate-specific antigen that became the foundation for PSA testing, has spent the last decade trying to convince doctors to stop using his discovery for routine screening in older men. The irony is striking. The man whose research launched millions of PSA tests now calls routine screening in seniors a medical disaster. Oblin has watched his scientific contribution become what he terms a profit-driven public health disaster that subjects men over 70 to unnecessary procedures and treatments that often cause more harm than the cancers they detect. PSA testing in men over 70 creates a dangerous cascade that frequently leads to biopsies and treatments for cancers that would never threaten their health or lifespan. The blood test detects a protein produced by prostate cells, but elevated levels can result from infections, inflammation, recent physical activity, or simply the normal aging process. When PSA numbers climb above arbitrary thresholds, doctors typically recommend biopsies to rule out cancer. These needle biopsies carry risks of bleeding, infection, and pain, Yet they often find slow-growing cancers that pose no actual threat to older men. Frank's experience illustrates how PSA testing can destroy quality of life in the name of cancer prevention. At 72, he played golf 3 times a week, traveled with his wife, and felt healthier than he had in years. His annual physical included a PSA test that showed slightly elevated levels. The urologist recommended a biopsy, which found small areas of cancer that the pathologist classified as low-grade and slow-growing. Despite Frank's excellent health and active lifestyle, the cancer diagnosis triggered an immediate treatment plan involving surgery to remove his prostate. The operation was technically successful, but Frank emerged with permanent incontinence and erectile dysfunction. He traded his active, confident lifestyle for daily struggles with adult diapers and the emotional toll of sexual dysfunction, all to treat a cancer that would likely never have caused him any problems. PSA levels fluctuate as unpredictably as weather forecasts, influenced by factors that have nothing to do with cancer. Riding a bicycle can elevate PSA levels for days. Recent sexual activity changes the numbers. Urinary tract infections, prostate inflammation, and even digital rectal exams can cause PSA spikes that look alarming on lab reports but indicate nothing dangerous. The test lacks the precision that patients assume it provides. Yet abnormal results trigger medical responses that can permanently alter men's lives. Most prostate cancers discovered through PSA screening in seniors move like tortoises, growing so slowly that other health issues will likely arise first. Heart disease, stroke, pneumonia, or simply the natural aging process will affect most men over 70 before their slow-growing prostate cancer progresses enough to cause symptoms. Meanwhile, the medical system treats these tortoise-like cancers as if they're racing hares that require immediate pursuit and capture. This mismatch between cancer behavior and medical response explains why so many older men undergo treatments that harm them more than their cancers ever would. The cascade effect from abnormal PSA results follows a predictable pattern. One elevated PSA leads to repeat testing, then biopsy, then staging studies, then treatment consultations, then surgery or radiation, then follow-up care for treatment complications. Each step carries risks and costs, both financial and physical. Men who felt perfectly healthy before their PSA test often find themselves patients for life, dealing with incontinence, erectile dysfunction, and the psychological burden of being cancer survivors. Masculine psychology complicates prostate health decisions in ways that don't affect other medical screening. Men who ignore strange car noises for months will immediately seek medical attention for prostate concerns because cancer fear overrides their usual tendency to avoid doctors. This reversal of typical male behavior around healthcare makes men particularly vulnerable to overtesting and overtreatment. They approach prostate screening with unusual anxiety and compliance, following medical recommendations without the skepticism they might apply to other situations. Watchful waiting offers a dignified alternative to aggressive PSA screening and treatment for older men. This approach involves monitoring prostate health through symptoms and physical exams rather than chasing PSA numbers that may not indicate meaningful problems. Think of it like keeping an eye on a slow leak in your basement rather than tearing apart the entire house foundation to fix something that might never cause real damage. Many men find this approach reduces anxiety while maintaining their quality of life. The U.S. Preventive Services Task Force now recommends against routine PSA screening for men over 70, finding insufficient evidence that it improves survival rates while frequently reducing quality of life through unnecessary treatments. Men who undergo PSA screening after 70 face approximately a 50% chance of false positive results, leading to biopsies and treatments that often cause permanent side effects. The numbers show clearly that the risks of routine PSA screening outweigh the benefits for most men over 70. Most major urological societies now recommend against routine PSA screening in men over 70, unless they have specific symptoms or very strong family histories of aggressive prostate cancer. The American Urological Association and international urology organizations have updated their guidelines to reflect evidence about age-related risks and limited benefits. These recommendations represent a fundamental shift from previous decades, when PSA testing was encouraged regardless of age or health status. This pattern of medical interventions that seem protective but may actually increase health risks extends into other areas of senior healthcare, where the solutions sometimes create bigger problems than the original concerns they were designed to address. Test 4. The bone density trap. Bone density testing presents another area where medical screening can create more problems than it solves for seniors. DEXA scans, the standard test for measuring bone density, have created a medical paradox where the cure has become worse than the disease for many older adults. Research from 2025 reveals that osteoporosis medications prescribed after routine bone density screening have been linked to unusual fracture patterns that rarely occurred before these drugs became widely used. The femur bone, which should become stronger with medication, sometimes develops stress fractures after years of drug treatment. These atypical fractures happen suddenly, often while people are walking normally or doing everyday activities, not falling or experiencing trauma. The medical community discovered these unusual fracture patterns by accident when patients taking bone medications for several years began arriving in emergency rooms with identical injuries. Long-term users of bisphosphonate drugs, the most commonly prescribed osteoporosis medications, developed fractures in the middle of their thigh bones, where breaks almost never occur naturally. The drugs that were supposed to prevent fractures were actually causing them in some patients, creating a medical mystery that took years to understand and accept. Betty's story demonstrates how bone density screening can derail a senior's health rather than protect it. At 76, she felt strong and active, walking 2 miles daily and working in her garden. Her routine physical included a DEXA scan that showed osteopenia, a condition where bone density falls below average, but doesn't reach the threshold for osteoporosis diagnosis. The doctor explained that osteopenia often progresses to osteoporosis and recommended starting medication immediately to prevent future fractures. Betty had never broken a bone in her life and had no family history of fractures, but the test numbers convinced her to begin taking weekly bisphosphonate pills. 2 years later, Betty developed severe jaw pain that her dentist couldn't explain. The pain worsened over several weeks until she could barely eat solid food. Multiple specialists examined her before discovering that the bone in her jaw was dying, a rare condition called osteonecrosis that occurs almost exclusively in people taking bone density medications. The same drugs prescribed to strengthen her bones were literally killing the bone tissue in her jaw. Betty required multiple surgeries, months of antibiotics, and eventually lost several teeth. She stopped gardening and walking because the jaw pain and surgical complications left her weak and depressed. DEXA scans create bone report cards that generate anxiety about grades that may not reflect your actual fracture risk. Like school report cards, DEXA results compare your bones to statistical averages and assign grades based on standard deviations from normal. A T-score of -1 means your bone density is 1 standard deviation below the average for healthy young adults. This sounds alarming until you realize that half of all healthy people have below-average bone density by definition. The scores create artificial categories that turn normal variation into medical diagnoses requiring treatment. The grading system for bone density makes the same mistake as judging a tree's strength by measuring only its trunk density. A tree's ability to withstand storms depends on root depth, branch flexibility, wood quality, and overall health, not just how densely packed the trunk fibers are. Similarly, fracture risk involves bone quality, muscle strength, balance, coordination, and fall prevention, not just mineral density measurements. DEXA scans measure only one factor, while ignoring the broader picture of bone health and fracture prevention. This narrow focus on density numbers has led to widespread overtreatment with medications that carry serious side effects. Bisphosphonate drugs can cause severe digestive problems, including stomach ulcers and esophageal irritation that makes swallowing painful. Some patients develop muscle and joint pain, so severe they become disabled by the treatment meant to help them. The medications require complex administration schedules, taking pills on empty stomachs, remaining upright for hours, and avoiding certain foods and other medications. For seniors dealing with multiple health conditions and medications, these requirements create additional stress and opportunities for dangerous drug interactions. The ironic increase in certain types of fractures among long-term medication users represents the most troubling aspect of bone density screening. Women who took bisphosphonate drugs for 5 or more years developed atypical femur fractures at rates significantly higher than women who never took the medications. These fractures often occurred without trauma, sometimes while patients were simply walking or standing. The drugs that were supposed to prevent hip fractures were actually causing unusual thigh bone breaks that required surgical repair and lengthy rehabilitation. Fear drives much of the overtreatment that follows bone density screening. Osteoporosis marketing campaigns have created deep anxiety about fractures, particularly hip fractures that can lead to nursing home placement and reduced independence. This fear often overwhelms rational assessment of actual fracture risk, which remains low for most seniors without previous fractures or significant risk factors. Women with osteopenia face approximately the same fracture risk as women with normal bone density, yet many receive the same medications prescribed for severe osteoporosis. Fracture prevention represents an important health goal, but medication may not always provide the best answer. Weight-bearing exercise, resistance training, adequate protein intake, and fall prevention strategies address the multiple factors that influence fracture risk beyond just bone density. These approaches strengthen not only bones, but also the muscles, balance, and coordination that help prevent falls in the first place. Exercise programs designed for bone health can actually be more enjoyable than taking medications with complex requirements and side effects. Many endocrinologists now recommend focusing on fall prevention and functional strength, rather than chasing bone density numbers in healthy seniors. This approach addresses the primary cause of fractures in older adults, which is falling rather than weak bones. Simple modifications like removing throw rugs, improving lighting, installing grab bars, and maintaining regular exercise routines prevent more fractures than medications in seniors without previous breaks. This practical approach acknowledges that bone health involves much more than mineral density, and that preventing falls often matters more than treating test results. The pattern of screening tests that seem protective, but may actually increase health risks, becomes even more apparent when examining how the medical system approaches heart health in seniors without symptoms. Test 5, the cardiac stress test circus. Cardiac stress tests represent perhaps the most dangerous example of this screening paradox, routinely transforming healthy seniors into cardiac patients through unnecessary interventions. The irony runs deep. A test designed to detect heart disease frequently causes the very complications it aims to prevent. Emergency departments report increasing numbers of seniors arriving with chest pain, heart rhythm abnormalities, and even heart attacks triggered not by underlying disease, but by the stress test itself. The physical and emotional demands of these procedures can overwhelm aging cardiovascular systems that were functioning perfectly well before testing began. Age-related heart changes that appear abnormal on stress tests are often completely normal parts of the aging process, leading to false positive results in up to 40% of seniors over 75. The aging heart develops thicker walls, stiffer valves, and altered electrical patterns that look concerning to cardiologists trained to spot disease in younger patients. These changes rarely indicate actual heart disease or increased risk of heart attacks, but they trigger medical responses that treat normal aging as pathological conditions requiring immediate intervention. The testing technology can't distinguish between dangerous abnormalities and harmless age-related changes, creating a diagnostic dilemma that usually resolves in favor of more testing and treatment. Robert's experience illustrates how cardiac screening can transform a healthy senior into a chronic patient dealing with complications that never needed to happen. At 74, Robert walked 3 miles daily, maintained his own yard, and felt energetic enough to keep up with his grandchildren during weekend visits. His annual physical included a routine EKG that showed minor changes from previous years. The cardiologist recommended a stress test to investigate these changes, explaining that it would provide peace of mind about Robert's heart health. The test showed what the doctor called concerning abnormalities that required further investigation through cardiac catheterization. The catheterization revealed moderate blockages in 2 coronary arteries. Robert felt no chest pain, shortness of breath, or other symptoms, but the cardiologist recommended stent placement to prevent future heart attacks. The procedure appeared successful, but Robert developed complications that included bleeding at the catheter insertion site, kidney problems from the contrast dye, and blood clots that required months of blood-thinning medications. He went from feeling healthy and active to managing multiple medications, dealing with fatigue from blood thinners, and living with constant worry about his heart condition. The stress test that was supposed to reassure him about his cardiovascular health, instead, created a cascade of medical problems that dominated the rest of his life. Stress tests create anxiety rather than relieving it, functioning like cardiac auditions where everyone over 70 is expected to perform like they're still 30 years old. The testing protocols were designed for younger hearts that can handle intense physical demands without complications. Seniors are asked to walk on treadmills at speeds and inclines that challenge their balance, coordination, and joint health, along with their cardiovascular systems. The testing environment itself creates stress, with multiple monitors, medical personnel, and the underlying assumption that something might be wrong with their hearts. Many seniors arrive at stress test appointments already anxious about what the results might reveal, adding emotional stress to the physical demands of the procedure. A 75-year-old heart that can't match the performance metrics of a 40-year-old heart gets labeled as abnormal, even when it functions perfectly well for its age and circumstances. The testing criteria fail to account for normal aging changes, creating situations where healthy seniors fail tests that weren't designed for their age group. This mismatch between testing standards and aging physiology explains why so many seniors receive abnormal stress test results despite having no symptoms or functional limitations. Abnormal stress test results trigger a predictable cascade that leads to catheterizations, stent placements, and lifelong complications for many seniors who felt fine before testing began. The medical system treats stress test abnormalities as medical emergencies requiring immediate investigation and intervention. Cardiac catheterization involves threading catheters through blood vessels to inject contrast dye and take detailed pictures of coronary arteries. This invasive procedure carries risks that increase with age, including bleeding, infection, kidney damage from contrast dye, and stroke from dislodged arterial plaques. When catheterization reveals blockages, the medical momentum almost inevitably leads to stent placement or bypass surgery, even in patients without symptoms. These interventions carry significant risks for seniors, whose blood vessels may be more fragile and whose kidneys process contrast dye less effectively than younger patients. Stent placement requires lifelong blood-thinning medications that increase bleeding risks, while bypass surgery involves major operations that can cause cognitive changes, infections, and prolonged recovery periods. Seniors who undergo these procedures often emerge with more health problems than they had before testing revealed their abnormal hearts. The aging heart naturally develops changes that look alarming on stress tests, but don't actually increase heart attack risk in people without symptoms. Coronary arteries develop collateral circulation that bypasses blockages, electrical conduction systems adapt to age-related changes, and heart muscle adjusts its function to maintain adequate blood flow. These adaptive changes often appear pathological on testing equipment designed to spot disease in younger hearts. the medical system struggles to distinguish between harmful disease and successful aging adaptations, usually erring on the side of intervention rather than observation. Symptoms provide more reliable information about meaningful heart problems in seniors than stress test results. Chest pain during physical activity, shortness of breath that limits normal activities, or fatigue that prevents routine tasks indicate heart problems that warrant medical evaluation. These symptoms reflect actual functional limitations rather than test abnormalities that may not affect daily life. Seniors who pay attention to their bodies and report concerning symptoms often receive more appropriate cardiac care than those who undergo routine screening that detects problems requiring no treatment. Statistics from 2025 show that routine stress testing in asymptomatic seniors leads to more cardiac procedures, but not better health outcomes compared to symptom-based care. Seniors who undergo routine stress testing face higher rates of catheterization, stent placement, and cardiac medications without experiencing fewer heart attacks or living longer than those who avoid screening. The testing frequently detects problems that never would have caused symptoms or shortened life expectancy, leading to treatments that reduce quality of life without providing meaningful benefits. Major cardiology organizations now recommend against routine stress testing in seniors without symptoms, instead focusing on lifestyle factors and symptom awareness for maintaining heart health. The American College of Cardiology, American Heart Association, and other professional societies have updated their guidelines to reflect evidence that routine cardiac screening often harms rather than helps asymptomatic older adults. The pattern of well-intentioned medical interventions creating unintended consequences extends beyond the physical risks we've discussed. These testing cascades carry financial implications that can devastate seniors on fixed incomes in ways that many never anticipate when they agree to routine screenings. The economics of overtesting. Medical testing costs create a hidden drain on senior finances that extends far beyond the initial procedure fees. The average senior spends over $3,000 annually out of pocket on unnecessary medical testing, even with Medicare coverage. This figure doesn't include indirect costs like transportation to multiple appointments, time lost from enjoyable activities, or the emotional toll of dealing with medical bureaucracy. Seniors on fixed incomes often discover that their retirement savings disappear faster than expected, not because of luxurious spending or poor planning, but because of medical tests that create more problems than they solve. The medical system generates enormous profits from testing volume, creating financial incentives that may conflict with what's best for senior patients. Hospitals, imaging centers, and laboratories depend on steady streams of testing revenue to maintain operations and profit margins. Each mammogram, stress test, or colonoscopy generates fees for multiple providers. From the facility performing the test to the radiologist's reading, results to the specialists providing follow-up consultations. This testing economy creates subtle pressures to recommend procedures regardless of whether they benefit individual patients, especially when those patients have insurance coverage that guarantees payment. When routine tests produce abnormal results, they trigger cascades of additional expenses that multiply rapidly. Follow-up appointments with specialists cost hundreds of dollars each. Additional imaging studies to investigate abnormal findings add thousands more. Biopsies, surgical consultations, and treatment procedures can generate bills totaling tens of thousands of dollars, all stemming from a single screening test that was supposed to provide peace of mind. Seniors often find themselves trapped in this financial cascade without understanding how a simple screening led to such enormous expenses. Medical bills have become harder to decode than tax returns, filled with mysterious codes, duplicate charges, and fees that multiply like rabbits. Facility fees, professional fees, technical fees, and interpretation fees can all appear on a single bill for one procedure. The same test might generate separate charges from the hospital, the technician who performed it, the doctor who ordered it, and the radiologist who read the results. Seniors spend hours on the phone with billing departments trying to understand charges that seem to appear from nowhere, often discovering that procedures they thought were covered actually included expensive components that Medicare doesn't pay for. Insurance coverage creates a dangerous illusion that medical tests are essentially free, when they actually cost the healthcare system enormous amounts that ultimately get passed back to patients through higher premiums, deductibles, and copayments. Medicare pays billions annually for screening tests that medical societies now consider inappropriate for seniors. But this spending doesn't disappear into thin air. The costs return to seniors through increased Medicare Part B premiums, higher supplement insurance costs, and reduced coverage for services they actually need. The opportunity cost of excessive medical testing represents money that seniors could spend on things that actually improve their quality of life and health outcomes. $3,000 spent on unnecessary testing each year could pay for gym memberships, healthy food, home modifications to prevent falls, or social activities that provide genuine health benefits. Seniors could hire housekeeping services, purchase mobility aids, or fund transportation to visit family and friends. The money spent chasing abnormal test results in healthy seniors could support activities and services that demonstrably improve both physical health and emotional well-being throughout their retirement years. Medical testing marketing has evolved to resemble infomercials that promise peace of mind, but deliver anxiety, expense, and often worse health outcomes than doing nothing. Healthcare marketing materials feature smiling seniors who supposedly gained confidence and security through regular screening. But these advertisements never mention the patients who suffered complications, financial hardship, or reduced quality of life after testing detected problems that never needed treatment. The marketing emphasizes fear-based messages about diseases that might be lurking undetected, while downplaying the risks and costs associated with the screening process itself. Financial toxicity from medical overtesting has become a recognized phenomenon where healthcare costs force seniors to make impossible choices between essential needs and medical bills. Seniors skip meals to pay for follow-up appointments triggered by abnormal screening results. They choose between purchasing prescribed medications and paying heating bills during winter months. Some seniors delay necessary home repairs or avoid visiting family because unexpected medical expenses consumed their discretionary income. The stress of these financial decisions often causes more health problems than the conditions that testing was supposed to detect. The cascade of expenses from a single abnormal test result can quickly exhaust seniors' emergency savings and push them toward financial crisis. A routine mammogram that detects a suspicious area leads to additional imaging, specialist consultations, biopsy procedures, and potentially surgery or treatment. Each step generates separate bills that arrive weeks apart, making it difficult for seniors to budget or understand the total financial impact. Medicare may cover portions of these expenses, but co-payments, deductibles, and uncovered services can easily total thousands of dollars. Research data from 2025 reveals that the average senior spends approximately $4,200 annually on medical testing and follow-up procedures that provide no health benefits, with some spending significantly more when screening results trigger extensive workups. This spending represents a substantial portion of typical Social Security payments and retirement income, forcing seniors to reduce spending on housing, food, transportation, and other necessities. Being selective about medical testing represents both smart health management and essential financial planning for seniors living on fixed incomes. Understanding the true costs of testing, including the potential cascade of follow-up expenses, helps seniors make informed decisions about which procedures provide genuine value. The money saved by avoiding unnecessary testing can support the activities, services, and lifestyle choices that actually contribute to healthy aging and life satisfaction during retirement years. Yet the financial pressures seniors face represent only part of a larger story about why these testing patterns persist despite mounting evidence of their problems. The forces driving medical overtesting operate largely behind the scenes, influencing medical decisions in ways that most patients never fully understand. What your doctor won't tell you. Most doctors won't openly discuss the unspoken pressures that drive them to order unnecessary tests for seniors. But understanding these hidden forces can help you make better decisions about your healthcare. The medical profession operates under intense legal and institutional pressures that create powerful incentives to overtest patients, especially older adults who are perceived as higher-risk populations. Malpractice attorneys have taught doctors that ordering tests provides legal protection, even when those tests aren't medically necessary. The fear of missing something, no matter how unlikely or insignificant, often outweighs concerns about the risks and costs of unnecessary testing. Defensive medicine has created a medical culture where doctors feel safer ordering tests than explaining why tests aren't needed, even when the explanation would be more beneficial for patient health. Having difficult conversations about aging, mortality, and the limitations of medical intervention requires time, skill, and emotional energy that many healthcare systems don't support or compensate. It's much easier to order a colonoscopy than to explain why a 78-year-old might be better off skipping it. Doctors can quickly check a box on an order form and move on to the next patient, while meaningful discussions about individual risk factors and personal values require extended appointments that don't fit into today's medical practice models. This communication gap leaves seniors vulnerable to cascades of unnecessary procedures because doctors avoid conversations that patients desperately need. When physicians order tests to address their own anxiety about missing something rather than addressing actual patient concerns, the focus shifts away from what seniors truly need. Many doctors struggle with discussing the realities of aging and the concept that some medical problems don't require intervention. These conversations require acknowledging mortality and the limits of medical technology, topics that medical training doesn't adequately prepare physicians to handle with confidence and compassion. Medical training transforms doctors into detectives who are rewarded for finding problems, but sometimes the mystery doesn't need solving, especially when the investigation causes more trouble than the original problem. Medical schools and residency programs emphasize diagnosis and intervention, creating physicians who feel successful when they discover abnormalities and order treatments. This detective mentality works well for acute illnesses and serious diseases, but it becomes problematic when applied to healthy seniors whose bodies show normal age-related changes. Doctors receive little training in recognizing when not to investigate findings that might be normal variants in older adults. Time constraints in modern medical practice make it significantly easier to order a test than to engage in nuanced discussions about risks and benefits with senior patients. Electronic health record systems allow doctors to order multiple tests with a few mouse clicks, while meaningful conversations about whether those tests make sense require significant time investment. The typical medical appointment now lasts less than 15 minutes, barely enough time to address acute concerns, let alone engage in shared decision-making about screening tests. Explaining why a test might not be appropriate requires discussing concepts like life expectancy, treatment tolerance, and personal values that can't be covered adequately in brief encounters. Liability concerns drive overtesting because doctors feel compelled to check every possible box to avoid potential blame, even when the likelihood of benefit is extremely low. Malpractice lawsuits rarely result from doctors who order too many tests, but missing a diagnosis can lead to legal action even when the missed condition would never have caused symptoms or shortened life. This legal reality creates powerful incentives to overtest seniors, particularly those with vague complaints or abnormal findings that might represent normal aging. The medical liability system fails to recognize that good doctoring for seniors sometimes means doing less rather than more. Geriatricians approach testing differently than other specialists because their training emphasizes functional outcomes rather than laboratory numbers or imaging findings. These physicians focus on whether seniors can maintain independence, enjoy their activities, and live according to their values, rather than whether their test results fall within normal ranges. Geriatricians understand that the goal of healthcare for older adults isn't to make their bodies function like those of younger people, but to support the best possible quality of life, given the realities of aging. This perspective leads to more selective use of testing and greater emphasis on interventions that directly improve daily function and well-being. The geriatric approach prioritizes conversations about what matters most to individual seniors, rather than following standardized protocols that apply the same testing strategies to everyone over 65. These specialists recognize that an active 85-year-old might benefit from different medical decisions than a frail 75-year-old, even when their chronological ages suggest similar approaches. Geriatricians spend time understanding each patient's goals, fears, and preferences before recommending tests or treatments. This individualized approach requires sophisticated clinical judgment and communication skills that extend beyond technical medical knowledge. Understanding these behind-the-scenes pressures that influence medical decision-making puts you in a much stronger position to advocate for yourself during medical appointments. The institutional forces, time constraints, and liability concerns that drive overtesting aren't going away, but recognizing them helps explain why your doctor might recommend procedures that don't align with your best interests. Armed with this knowledge, you can approach medical appointments with realistic expectations about the pressures your doctor faces and the questions you need to ask to ensure that recommended tests truly serve your health goals, rather than just institutional protocols or legal protection strategies. The art of saying no to your doctor. Learning to navigate these complex healthcare dynamics requires developing skills that most seniors never expected to need. You have far more control over your medical care than most people realize, and learning to say no to unnecessary tests can actually be one of the most important forms of self-care you practice. The medical system has trained patients to believe that questioning doctor recommendations shows disrespect or ignorance, but the opposite is true. Taking an active role in your healthcare decisions demonstrates wisdom, self-respect, and a commitment to your own well-being. The psychological difficulty of questioning medical authority runs particularly deep for seniors who grew up in an era when doctors were unquestioned authorities, whose recommendations were followed without discussion. This generation learned to view medical professionals as infallible experts whose judgment should never be challenged. The white coat effect remains powerful among seniors, creating an almost automatic deference that can prevent them from advocating for their own best interests. Breaking through this ingrained respect requires recognizing that good medical care involves partnership, not submission, and that doctors benefit from patients who ask thoughtful questions and share their concerns openly. Learning specific phrases and scripts can help seniors navigate these conversations with confidence and politeness. When a doctor recommends a test, you can respond by saying, "I'd like to understand more about this before deciding. Can you help me understand what we're looking for and how the results might change my treatment?" This approach shows genuine interest in understanding rather than reflexive opposition to medical advice. Another useful phrase is, "What would happen if we waited and watched instead of doing this test right now?" This question opens discussions about alternatives without seeming confrontational or dismissive. Sometimes doctors can resemble persistent salespeople who keep pushing products you don't need, requiring the same polite but firm techniques you might use with telemarketers who call during dinner. Just like dealing with unwanted sales calls, you can acknowledge their recommendation while maintaining your position. You might say, "I appreciate your concern for my health, but I've decided this test isn't right for me at this time." The key is remaining pleasant while being clear about your decision. You can also use phrases like, "I need some time to think about this," or "I'd like to discuss this with my family before deciding." Before agreeing to any medical test, ask 3 essential questions that can help you make informed decisions. First, will this test change my treatment or management? If the answer is no, or if the doctor seems uncertain, the test may not be necessary. Second, what happens if I don't do this test? Understanding the consequences of declining can help you weigh risks and benefits accurately. Third, what are the risks and potential complications of this test? Every medical procedure carries risks, and you deserve to understand them before consenting. These questions shift conversations from automatic acceptance to thoughtful evaluation of medical recommendations. Preparing for medical appointments helps you avoid being pressured into unnecessary procedures during the limited time you have with healthcare providers. Write down your questions beforehand so you don't forget important concerns during the appointment. Bring a list of your current symptoms, medications, and any changes in your health since your last visit. Consider bringing a trusted family member or friend who can serve as an advocate and help you remember important information discussed during the appointment. This preparation demonstrates that you're taking your healthcare seriously while ensuring you get the information needed to make good decisions. Many seniors worry about offending their doctors or being labeled as difficult patients if they question recommendations or decline suggested tests. This fear often prevents important conversations about treatment preferences and personal values. However, good doctors welcome informed patients who ask thoughtful questions and take active roles in their healthcare decisions. Physicians who become defensive or dismissive when patients ask reasonable questions may not be the best fit for seniors who want collaborative relationships with their healthcare providers. The concept of medical minimalism offers a framework for making healthcare decisions that prioritizes quality over quantity, similar to decluttering your home to focus on what truly matters. Just as you might choose to keep fewer possessions, but ensure they're meaningful and useful, medical minimalism involves choosing fewer medical interventions, but ensuring they align with your values and genuinely improve your health or quality of life. This approach doesn't mean avoiding all medical care, but rather being selective about which interventions provide real benefits versus those that create more problems than they solve. Medical minimalism for seniors involves focusing on treatments and tests that address actual symptoms or significantly improve daily function, while avoiding screening tests that might detect problems unlikely to affect your remaining years. This approach emphasizes symptom-based care over numbers-based care, paying attention to how you feel and function rather than chasing test results that may not reflect your actual health status. Redirecting conversations towards symptom-based care requires gentle but clear communication with healthcare providers. You might say, "I'm more interested in addressing symptoms that are bothering me than looking for problems I can't feel." This approach keeps the focus on issues that actually affect your daily life rather than abstract numbers or potential future problems. You can also ask, "How will this test help me feel better or do the things I enjoy?" This question forces healthcare providers to explain the practical benefits of recommended procedures rather than relying on abstract medical reasoning. Taking control of your medical decisions isn't disrespectful to healthcare providers or ungrateful for their expertise. Instead, it represents taking responsibility for your own well-being and ensuring that medical care honors your values, preferences, and goals for your remaining years. This approach leads to more satisfying healthcare relationships where you and your doctors work together toward outcomes that truly matter to you. Once you understand how to navigate the medical system more effectively, you can shift your focus toward the approaches that actually do support healthy aging. Better ways to stay healthy after 70. The most powerful health interventions for seniors aren't found in high-tech medical facilities with expensive equipment and complex procedures. They exist in simple approaches that have sustained human health for generations. While the medical system focuses on detecting problems through sophisticated screening tests, research consistently shows that basic lifestyle factors have far greater impact on how well seniors age than any diagnostic procedure. The irony is striking. We've become so focused on finding diseases that we've forgotten the fundamental practices that prevent them from developing in the first place. The shift from what not to do toward what seniors should focus on reveals a completely different approach to health maintenance. Instead of chasing abnormal numbers on lab reports or worrying about screening results, The evidence points towards simple daily practices that actually determine how well you'll feel and function in your later years. This positive approach to senior health emphasizes building strength, maintaining connections, and engaging with life rather than hunting for potential problems that may never cause symptoms. The research from 2025 makes this clear. Seniors who focus on positive health behaviors consistently outperform those who undergo extensive medical screening. Evidence-based lifestyle factors demonstrate more influence on senior health outcomes than any screening test currently available. Regular physical activity, adequate sleep, social connections, and nutritious eating patterns predict how seniors will age far more accurately than colonoscopy results, bone density scores, or cardiac stress test findings. These lifestyle factors work together, creating compound benefits that no single medical intervention can match. A senior who walks daily, sleeps well, maintains friendships, and eats reasonable meals will likely enjoy better health than someone who undergoes every recommended screening test, but neglects these basic foundations of well-being. The most powerful health interventions turn out to be things your grandmother already knew without needing medical research to prove their value. Sleep, movement, social connections, and good food formed the cornerstone of health wisdom long before modern medicine existed. Your grandmother didn't need studies to understand that people who stay active feel better than those who don't, or that loneliness makes people sick while friendships keep them healthy. She knew that regular meals with fresh ingredients provided more energy than processed foods, and that consistent sleep schedules helped people function better during the day. Modern research has simply confirmed what traditional wisdom always understood about maintaining health through simple, sustainable practices. Functional fitness matters infinitely more than knowing your exact test results or laboratory numbers. Consider two different 80-year-olds. One can climb stairs without difficulty, carry groceries, garden for hours, and travel independently, while the other knows their precise cholesterol level, bone density score, and PSA number but struggles with basic daily activities. Which person demonstrates better health? The ability to function independently, maintain balance, and perform meaningful activities reflects true health status far more accurately than any collection of test results. An 80-year-old who climbs stairs confidently possesses something no medical test can measure: the physical capacity and confidence to live life fully. Functional fitness encompasses strength, balance, flexibility, and endurance in ways that support real-world activities rather than abstract health metrics. This approach focuses on whether you can get up from chairs without assistance, walk distances that matter to you, carry items you need, and maintain the physical independence that supports your chosen lifestyle. These capabilities directly impact your daily experience and quality of life, while test results often have no connection to how you actually feel or what you can accomplish. The senior who can dance at family celebrations demonstrates better health than one whose latest blood work shows perfect numbers, but who lacks the strength or confidence to participate in enjoyable activities. Symptom awareness and body literacy represent crucial skills that help seniors distinguish between normal aging changes and situations requiring medical attention. Learning to recognize your body's patterns, understanding what constitutes normal variation in your energy levels, sleep quality, and physical comfort helps you identify when genuine problems arise. This internal awareness often proves more reliable than screening tests for detecting meaningful health changes. Your body provides constant feedback about its condition through symptoms, energy levels, and functional capacity. Seniors who develop this body literacy can respond appropriately to real health concerns while avoiding unnecessary anxiety about normal aging changes that don't require medical intervention. Social connections and sense of purpose play essential roles in senior health, with relationships and meaningful activities providing benefits that surpass many prescription medications. Strong social ties reduce stress, support immune function, encourage healthy behaviors, and provide emotional resilience during difficult times. The joy and purpose that come from meaningful relationships and activities create powerful health benefits that no pill can replicate. Seniors who maintain active social lives and engage in purposeful activities consistently show better health outcomes than those who focus primarily on medical interventions. The concept of health span versus lifespan represents a fundamental shift in how seniors can approach their remaining years. Health span refers to the period of life spent in good health, free from chronic diseases and disabilities that limit independence and enjoyment. Lifespan simply measures how long you live, regardless of quality. Focusing on health span means prioritizing interventions that help you maintain function, energy, and engagement, rather than simply trying to extend life at any cost. This approach values the quality of your years over the quantity, leading to decisions that support active, independent, satisfying aging rather than mere survival with extensive medical management. Research from 2025 identifies the most effective interventions for healthy aging, emphasizing approaches that remain accessible to most seniors regardless of their financial resources or medical complexity. Regular physical activity, even simple walking programs, produces more health benefits than most medical treatments. Adequate sleep, typically 7 to 8 hours nightly, supports immune function, cognitive health, and emotional well-being better than many medications. Social engagement through family, friends, community activities, or volunteer work provides protection against depression, cognitive decline, and physical deterioration. Nutritious eating patterns focused on whole foods rather than restrictive diets support energy and function throughout the aging process. The best preventive medicine for seniors isn't found in medical facilities with their expensive equipment and complex procedures, but in daily choices, relationships, and staying engaged with life. This represents a fundamental shift from medicine-centered approaches to life-centered approaches to healthy aging. Simple daily practices like taking walks, maintaining friendships, eating reasonable meals, getting adequate sleep, and staying involved in meaningful activities create the foundation for successful aging that no medical screening can provide or replace. Understanding these principles prepares you to make thoughtful decisions about when medical intervention serves your goals and when it might work against them. The choice between medical intervention and natural aging becomes clearer when you understand the true risks and benefits of common screening tests. This balance becomes essential after age 70, when many screening tests shift from helpful to harmful. You now possess the knowledge to distinguish between necessary medical care and potentially dangerous overtesting. Start having honest conversations with your doctors about your values and priorities for your remaining years. Ask the important questions we discussed. Remember that taking control of your medical decisions represents an act of self-respect that can lead to more peaceful, enjoyable senior years focused on what truly matters.